Now I want to call your attention, this is a list that I drew up based upon a half dozen studies, including a study of HR 676. If you ask how much a single payer bill can save, the answer is probably on the order of 15 to 20% if you don't touch provider income. So you can say to every hospital and doctor in America, we're not proposing to slash physician and hospital income on average. We're going to raise Medicaid rates, we're going to bring some other types of payment down, but on average, provider reimbursement doesn't change. That's essentially what the argument was for HR 676, and when we get to it, you'll see that Pramila has adopted roughly that strategy. Bernie didn't. Bernie's bill says rates will come down to Medicare levels. And I think you all know that a study put out by a conservative think tank called the Mercatus, I can't remember what the Mercatus something or other, came out with a report that said Bernie's bill will save a little money, but only by slashing provider, doctor, and hospital rates by 40%. That's a gross misrepresentation of what a single payer can do. Of course they would say that. They're not about to give single payer its due. But anyway, if you ask, let me just jump ahead here and see if I can. If you ask, where is my, here we go. If you ask, well, what about a system like Canada, which is spending half what we're spending? So Kip, why are you standing up there and telling me that an American single payer bill can only cut costs by 15 to 20%? Why isn't it 50%? Well, there's a twofold answer. The Canadians don't offer, they don't cover a lot of things. They don't cover dental care. I think they've started to take a crack at long-term care. Their drug coverage is very weak. I think they offer coverage to poor people. So that's one reason. The coverage in Canada is often described as deep and narrow. And then there's a whole, so physician and hospital coverage is excellent. But there's a lot of stuff that's not covered. So that's one reason why we can't claim to get to Canadian levels, because we're going to offer a lot better coverage. The other reason is we're not proposing immediately or even in the short term to get physician and hospital reimbursement rates down to Canadian levels. So if you do those two things, you offer much richer coverage and you forego the opportunities to use the power that comes with a single payer to reduce physician and hospital and other provider pay to Canadian levels, then you're talking more like a 15 to 20% savings. Now what that means is, to come back to my last slide, what it means is that instead of being able to cut by 40 to 50%, you see the total savings there is probably on the order of 15 to 20%. And then you have to offset that with increased utilization or consumption of medical care. And there's two reasons. Number one, there's no more uninsured people. And uninsured people use about half the services that insured people use. So if you say we're going to insure the uninsured, that will drive up utilization, and it should. And if you say we're going to eliminate out-of-pocket payments, well, shoot, you've got 90% of Americans who have insurance, but big out-of-pocket payments, and now you're bringing those down too. So that will increase utilization slightly as well. And that combination then is and you add long-term care. That's an expensive piece of any universal coverage bill. Your total utilization is probably going to go up 15 to 20%. Now, you look at a lot of other research out there, you'll see some people predicting a utilization rate of 8%. You may all recall that Growth and Justice put out a report on single payer that they cooked up. And the Lewin group said utilization will only go up 8%. When I see a number like that, I'm thinking, no, they just didn't offer the coverage that HR 676 and our Minnesota Care Bill, our Minnesota Health Plan Bill, or the new HR Pramila's new bill is offering. So keep that in mind, because that might be an option. We may want to say, Well, we do want to bring some provider reimbursement rate down in order to increase savings.
Yep.
Yes.
I keep hearing 30% savings on administrative costs. But that also includes marketing and all that kind of stuff. But you've got 10 to 15%, half, half. Is it 10, 15% per side, or is it just 10 to 15%?
That 30% number everybody hear his question, he hears that the total wasted amount in administration is 30%. That 30% number you're hearing is the total amount that America spends on administration. Now that doesn't mean that that 30, 31, 32% is totally wasted. I mean, every human enterprise has to have some administrative cost. A high school choir has an administrative cost. We think that you could, that Canada operates, they devote 15% of their entire healthcare bill to administration. We're devoting 30, 31, 32%. And so when you see in the top line there, savings of 10 to 15%, that's based on a couple of studies that have, some that have used Canada as a model and others that have used others. I think 15% is realistic. I don't think it's realistic at the state level because we're still going to have Medicare and Medicaid initially. But at the national level, I think you could bring total administrative spending down from 30% of our total bill to 15%. And what I meant to say by this line here was that half of that 10 to 15% savings is from the insurer sector, because now you're going to one payer, and the insurance industry operates with 20% overhead, and you're going to get that down to about 2%, which is what Medicare operates at. And then there's the provider sector. Hospitals and doctors have overhead. It is very high because we're in a multiple payer system, and the 1,000 insurance companies all have their own hoops for everybody to jump through, and to turn the doctors into data entry clerks in order to make them document what they're doing and show quality. And so when you go to a single payer system, you're reducing the overhead of the insurer sector and the provider sector. That's where you get that 10 to 15%. Is that making?
Yeah. The other question goes right with it. Senator Jensen's been talking about all the paperwork that he has to do on every patient. He has to document everything. With single payer, we'll be able to eliminate a lot of that, all that paperwork?
No, you will. We will for hospitals. We will not eliminate paperwork for physicians. What we will do is make the paperwork uniform. It would be going to the uniform fee schedule like Medicare for doctors. And thanks to Pramila Jayapal's new bill, she's going to strip out all of that quality control, value-based payment stuff that is turning doctors into data entry clerks. So two things will happen. The billing rules are now become uniform, and there will be no more of this constant intervention with you have to buy electronic medical records, you have to click on a box that said, did you talk to the patient about not smoking? Do you understand that diabetics have to have their kidneys examined once a year? Please click on the box and say, tell us you did that. All that's going to go away.
Kip, could you comment on the drug prices? It seems like if we could negotiate drug prices, we might be able to do better than 4% savings, or I'm not sure. I understand that.
I probably should have said right away, these percentages are all as a percent of the 3.5 trillion we spend on healthcare nationally. And so if I say drug price controls are going to save 4%, I mean it's going to reduce the 3.5 trillion by 4%. It will probably, I think what you're thinking is what will happen to the average drug. Our drug prices are insane compared to countries that actually try to control. So I think if you were to ask me what's going to happen to the average drug price, I think it's going to drop by 20 to 30%, possibly. Some of them are going to drop by half. But good question. Thank you.